Hello people, in this video let us look at prolapsed rectum, rectal prolapse. So the rectum, as such, the rectum has come out. You can see here, this is rectal prolapse. It can be painful or painless, they have said. Let's look at this. So here is an actual image of a person with that person's rectum out. Doesn't look good at all, right? Doesn't sound good either. So what is rectal prolapse? It is the protrusion of the mucous membrane or the entire rectum outside the anal verge. Okay, this is rectal prolapse. If mucous membrane is out, you can say partial rectal prolapse. If entire rectum is out, then you can call it as complete prolapse. Okay, this is very common in children and elderly. Okay, what are we looking at? We are looking at rectal prolapse. Very good. What are the two types? You know, partial and complete. Very good. So you have partial prolapse and complete prolapse. Partial is where the protrusion is between, it's around 2 to 3 centimeter, you can say. It is a mucosal prolapse usually. A complete prolapse is where you have full thickness prolapse, full thickness, not just the mucosa. So you have mucosa, submucosa, muscularis, serosa, all the layers are coming out. That is called as Procidentia. So full thickness prolapse means it's not just the mucus layer, it is all the 4 layers, remember. This is defined as protrusion of the rectum for more than 3.7 centimeter outside the anal verge. So when you measure it outside, you should be able to measure more than 3.7 centimeter. So that will tell you that it is a complete prolapse. Okay. So you have partial prolapse which is less than 3.7 and greater than 3.7 is complete. Okay. So the entire rectum which protrudes out on straining, sometimes along with the peritoneal sac. So you just ask the patient to strain, okay, just ask him to squat and strain and everything comes out and you can see and measure. If it's more than 3.7, it is complete prolapse. Here they are showing you complete prolapse when this person squat and strains. Let us look at partial prolapse. So partial prolapse, let us focus a little more on this. Partial prolapse, basically it is in infants. They are saying whooping cough can cause or habitual constipation, or if there is a underdeveloped sacral curve, etc. So basically developmental issues they are saying, okay. If there is some obstetric trauma in adult female, torn perineum, all this. So basically you can understand that there are some minor causes for this partial prolapse. How will you treat? You just put it back with the finger. So this is anyways temporary, you just put it back. Advise the mother, if it is an infant who's having the problem, advise the mother to just use her finger with some lubricating jelly and put the prolapse inside. Then you can also give some EthanolAmine Oleate into the submucosa, so it will cause aseptic fibrosis. So what will happen? The mucosa gets tethered to the other layers. So you're just injecting some EthanolAmine Oleate to cause fibrosis. Okay. Then partial prolapse you can excise after applying Goodsall's ligature. You can also excise it. So that becomes the surgical part of it. Okay. So did you understand? Partial prolapse is very easy, right? It happens because of some minor things like some constipation and whooping cough and etc. So treat it, just put it back. Partial, they don't care so much. Now let us go to the complete prolapse. Okay. How is it going, people? Shall we look at the complete prolapse? Okay. Now we are shifting focus to the complete prolapse. So look at actually what they are happening here. There is internal intussuception, okay, so basically telescoping kind of a thing. So here one pipe is there, let us say. Inside that this smaller pipe goes, okay, so this is like a telescope. So the near the rectum, right, so the rectum somewhere around that there is this intussuception, whereas this telescoping, okay, because of some diarrhea, constipation, etc. or some disorder of the pelvic floor. Now the rectum prolapse will occur, okay. So what will happen? There will be pain, incontinence, prolapse like we told you. Further progression of this prolapse, what will happen if the prolapse continues to happen? There will be ischemia and gangrene. Okay, so this is the prolapse. Okay, this much you remember. That's enough. What is tenesmus? Tenesmus means they don't feel like they have evacuated the blood bowel. Okay, that is tenesmus. They don't have a sense of evacuating the bowel. So they always feel like they have to pass stools, but so that is the feeling. So that will lead to prolapse, okay, that will lead to ischemia, gangrene, etc. Here they are showing you how the uterus, a part of the uterus and the rectum has prolapsed, okay, this is called as Procidentia. You should know this, it will come even in gynecology, right? So this is uterine prolapse with this rectum prolapse, Procidentia. Especially in multiparous women it can happen, okay. So you can see this more in females. The constipation can be an important factor, and when you ask the patient to strain, you can see the entire rectum descending down. So this will tell you it's a complete prolapse. Okay. Now when you see something hanging down like that, you should know the differential. Can it be a hemorrhoid? Right, that's just the veins coming out, or could it be a polypoid tumor? Could it be the prolapse of the sigmoid colon? So is it the rectum or the sigmoid colon? All this you'll have to check. So it looks like even sigmoid colon can come out. Even when sometimes if there is intussuception and the mesentery is very long, even that intussuception can come out of the anal verge, right? So all this you have to rule out. Okay. Now we will treat it. So for complete prolapse, they are talking about surgery only. Okay. For complete prolapse, they are talking only about surgery. So surgery, they are talking about perineal procedures and abdominal procedures. Okay, two types of procedures. Perineal means you can go from down and fix it, right? That is what perineal. Abdominal means you have to cut open the abdomen and fix. Okay. So look at this one surgery that they have shown here. See, they have around this mesh, around this rectum, they have put some mesh and fixed it to the sacrum, looks like, right? Mesh is sutured to the sacrum posteriorly and sutured to the sides of the rectum. Okay. So this is the mesh repair of this rectum. Okay. So that it needs some support, right? So they are giving the support. So this is abdominal surgery. Now anyways, let's get started with the surgery techniques. So surgery techniques, you should know there are two: perineal, going from down, or from abdomen. If you cut and go, that becomes abdominal surgery. Now let's look at perineal surgery. You have the Delorme procedure, reefing the rectal mucosa. Actually, they are not doing this anymore, looks like, because it will cause a lot of relapse. So anyways, they are showing you what procedure they are doing here. So here they are reefing the rectal mucosa. So the prolapse is completely averted, mucosa is stripped and muscle coat is plicated. Okay, they'll maintain the mucosal continuity. This is an easy operation, but relapse are high. Okay, it does not correct the defect. Then let us go to Altemeier procedure. Altemeier procedure, basically they are doing perineal proctectomy and posterior sphincter enhancement. Okay, so this is what they are doing here. So in this operation, Altemeier procedure, they seem to be removing the rectum, which I really don't like. I really don't like removing rectum. They seem to be removing the rectum. Okay. So just understand this, the full thickness of the prolapsed rectum along with the sigmoid, they are excising. They are removing even part of sigmoid. Okay. Removing rectum with part of sigmoid. Okay, so they are doing perineal proctectomy and posterior sphincter enhancement. Okay, and they are anastomosing the remaining part of the sigmoid to the anal canal. So I don't like this at all. This will lead to urgency and incontinence. So imagine pooping inside your underwear. So it will lead to incontinence. Leads to urgency and incontinence. Who wants to do this? I don't like it at all. You're removing the rectum and a part of the sigmoid colon. I don't like that. Now let us go to Thiersch wiring. This is very easy. Okay, this sounds like just take some steel wire or some silk suture. SILK, silk suture. And just put it around the anus and tie it. So just take steel wire or thick silk suture and apply all around the anus. So this is anal encirclement. Okay. So if you want, you can try this. Push everything back. First of all, inside you have to push everything. All the prolapse you have to push it in, and then you have to put some ring around the anus. Okay. This is Thiersch wiring. Steel wire used. Altemeier is, I don't like Altemeier. They are removing the rectum and the part of the sigmoid colon. We don't like that. Delorme is reefing the rectal mucosa. If you can remember, oops, so many terminologies, right? Try to say it. Delorme, Altemeier, and one more. Thiersch wiring. Very good, very good. Now let's go to abdominal procedures. You have the Wells operation, Ripstein Sling operation, mesh rectopexy, and Lahaut operation. Everything you are going via the abdomen, remember. So what will you do? Abdomen, you can do laparoscopically or open. Anyways, they are doing laparoscopy here. The rectum is pulled upward and sutured to the sacrum. So you just go laparoscopically. So you will pull up the rectum and suture it to the sacrum posteriorly with the help of a polyvinyl alcohol sponge kept behind the rectum. Okay. So you just suture it posteriorly. Okay. There will be a dense fibrotic reaction and that will fix the rectum. Okay. That's all we want, right? So pull it up and posteriorly fix it, as simple as that. Now let us go to Ripstein Sling operation. So basically here what is happening, there is a sling that you're putting. So just remember there is some sling and you're trying to give support to the rectum. Okay. Then mesh rectopexy. So here we told you that this is the procedure of choice today. You will use this mesh and you will fix it. So to the sacrum again. So this is the gold standard. Okay. There will be fast recovery, less pain, short hospital stay. So very important. This is the procedure of choice today. And they are saying that some people will resect sigmoid with this procedure. That is called as Goldberg operation. If they resect the sigmoid, then it is Goldberg operation. Anyways, now let us go to Lahaut operation, which is the gold standard, which is a procedure of choice, guys. Mesh rectopexy. Okay. So draw this diagram also in the exam so that you can get some nice marks. Okay, draw the sacrum and here you draw the rectum and put one mesh around here and suture it here. They've shown the anal canal. Very easy, right? To draw it. Draw this diagram. Okay, now coming to Lahaut operation. So anchoring the rectosigmoid to rectus sheath. If possible, remember this. Lahaut's operation. So there you are anchoring the rectosigmoid to rectus sheath. So the abdominal wall, right? Anterior abdominal wall, somewhere there. They are anchoring it. Think that all these procedures are very easy to think. You put one sling, one mesh, one wire, one ring, circling, encircling, etc., etc. So it's very easy to understand. The thing that is difficult here to remember are these names, right? But anyways, you have understood now that there are some perineal procedures where you can put the mucosa up and you can remove the rectum and part of sigmoid, or you can put some Thiersch wiring where you will put steel wire. Okay, focus people, focus. Okay. Then abdominal procedures, you go and you pull the rectum up and suture it to the sacrum, or you put some sling or mesh rectopexy, which is the gold standard. This is what you have to write in the exam. Lahaut's operation, where you will anchor the rectosigmoid to the rectus sheath. Okay. So in this video, you have looked at the prolapse rectum. Bye bye.